Well, good morning. First, I'd like to thank Mark and Helen Speakman for their kind hospitality during our stay here. And also congratulations to Frank Keeley and his organizing committee on really an outstanding scientific program. Second, I'd like to thank President Vora, Abe Rain, and the Executive Committee of IBUS for their kind invitation to participate in this outstanding session. My topic today will focus on flexible uteroscopy, the top 10 tips and tricks. The first tip with any surgery is to pick the right patient. I use the stone size of 15 millimeters to try to help guide myself as to whether the patient should have PCNL or shockwave lithotripsy. We see that our focus for discussion today, ureteroscopy, falls in the middle. So it has a role for both large stones and small stones in select patient populations. The first would be the patient who's anticoagulated. An anticoagulated patient who cannot come off their anticoagulation is best served with ureteroscopy, whether it's a small stone or a large stone. With regards to larger stones that may be otherwise amenable to PCNL, if there are other organs in the way that prevent an accurate and safe access into the kidney, be it the bowel, the pleura, the spleen, or the liver, that might be a reason to choose ureteroscopy over PCNL. Some people use morbid obesity as a relative contraindication for PCNL, though in our hands, PCNL seems to work fairly well in the morbidly obese. On the other side of the coin, a hard stone, Hounsfield units greater than 1,200, a stone that's deep because the patient is large, greater than 12 centimeters skin to stone distance, or a medium-sized stone in the lower pole would be indications to consider ureteroscopy as opposed to shockwave lithotripsy. The second tip is to be comfortable. We instruct our trainees to do ureteroscopy in a sitting position as opposed to standing position. To be able to do this, it's important not to use an endoscopic tower that's used for laparoscopy, but rather to have a flat panel monitor on a swivel arm that will come down to the eye level. If one tries to perform ureteroscopy sitting with a laparoscopic tower, it causes a high degree of cervical strain and can lead to disability of the surgeon. The other tip is to use an offset camera. With the offset camera, one's able to rotate the camera with your chin to keep it oriented up and down as you manipulate the scope throughout the kidney. So this helps maintain your orientation during flexible ureteroscopy. Another part about being comfortable is being dry. So it's important to have a good seal on your working channel so that your pressurized irrigation goes into the patient as opposed to onto your shoes. Tip 3 is to always use a safety wire. Just like when you drive your car, you put your seatbelt on, the same thing with your safety wire. Have a safety wire in at all times. This flies in the face of a few studies that suggest that a safety wire is not needed. Over 600 patients reported no complications without the use of a safety wire. But the key question to ask is, are you a basketer or are you a duster? And hopefully in 10 minutes you'll all be basketers as opposed to dusters. If you are a basketer, meaning that you actively extract fragments of stones after lasering them, then it's important to use a wire as a safety measure to be able to place a stent if needed. With regards to what type of wires, we keep 3 types of wires in our operating room. The sensor wires are all-purpose wire. It has a hydrophilic tip with a relatively stiff shaft. It's important to note that 2 companies have come out with good competitors to the sensor wire this year, the first being Olympus and the second being Bard. The other 2 specialty wires are a super stiff wire, for Amplat super stiff, that's used to place ureteral access sheaths or large stents, as these will help prevent buckling as one tries to advance these devices. And then a glide wire is important to have for passing an impacted stone where the sensor wire does not pass beyond it. Though the wire can be your friend, your wire can also be your enemy. The risk of perforation to the ureter has been reported to be somewhere between 1 in 1,000 to 5%, depending on whether one defines it as a full perforation or a mild mucosal flap. We can test a variety of characteristics of the wire in the laboratory. We can measure how much force does it take to perforate the ureter, how much force does it take to bend the shaft, how much force does it take to bend the tip around a stone, and how hydrophilic is the coating on the wire. For the perforation force, you want the highest force possible so that you have to really push hard before it perforates the ureter. And this is related to the stiffness of the tip as well as the sharpness of the tip. The bending force may be important with regards to placing sheaths or large stents. The bending of the tip is important to maneuver around the wire rather than just butting up against the stone. And the hydrophilic coating may be important. You might want it less hydrophilic if it's your safety wire, and more hydrophilic if it's your wire that you're trying to pass beyond an impaction. So if we look specifically at the types of wires that are commonly used to get beyond an impacted stone, we see that the glide wire and the zip wire are both favorable with regards to perforation, and they're also favorable for the other characteristics that one looks for in a hydrophilic wire. A new wire from Coloplast also demonstrates good safety with a high perforation force. And so it looks like there is some competition now for the Trumo glide wire in terms of the type of wire that you might choose to pass beyond an impacted stone. I get a lot of my knowledge from Snapple iced teas. They have little quotes underneath the lid, and this one says that fish can drown. So to me that means no matter how many times you do something, and passing a wire is one of the most common things we do, you can sometimes run into trouble. So here we see some extravasation in the distal ureter. The stone was actually up in the kidney, but at initial attempts to pass the wire, we met resistance, did a retrograde, saw some extravasation. So at this point, one might say, well, the next step is to put in a nephrostomy tube. But we see that there's continuity in the ureter, and so we would look in with a semi-rigid ureteroscope and try to pass a wire under vision. If we could get a wire up to the kidney under vision, we'd put up a stent and come 2 weeks later to try again with the ureteroscopy. Tip 4 is to always start with a semi-rigid ureteroscope, even if your plans are for flexible ureteroscopy to treat an intrarenal stone. The semi-rigid ureteroscope will dilate the intramural ureter. It allows you to check for unanticipated stones in the distal and mid-ureter. Perhaps a stone has fallen into the distal ureter in between when you obtained your imaging and when the patient reaches the operating room. The reason this is important is because if you're planning to place an access sheath, the access sheath can push a stone into the wall of the ureter if you don't realize that it's there. And the third tip is that the semi-rigid ureteroscope can be used to place your second wire, which will be the super stiff wire, which you'll use to place your access sheath. So this helps you save a bit of money in that you don't have to open a dual lumen catheter or a coaxial dilator to place a second wire. With regards to tips for semi-rigid ureteroscopy, it's commonly recommended to try to get underneath the wire and lift it up. Though typically the ureteral orifice will tell you whether to go left, right, up, or down, depending on where it appears to be the most capacious. Now on occasion the ureteral orifice will be tight, in which case it may be helpful to have a smaller scope. This needle scope from Wolf has a 4.5 French size, which is especially helpful in pediatrics, but also in adults with a tight ureteral orifice. Another trick, if it's tough to get in the ureteral orifice, is to use the railroad technique. At the top we have our safety wire, which was the sensor wire that was placed cystoscopically. Below we have a super stiff wire, which is being placed through the working channel of the ureteroscope. Once you have two wires in, one rotates the scope until the scope is lying in between the two wires, and then advance it gently to try to advance beyond the point of obstruction. The next step really comes back to the question of, are you a duster or are you a basketer? The dusters say that we focus on safety. No need for a basket, no need for a wire, no need for a sheath, no need for a stent. If we're just going to dust the stone, by dusting the stone we avoid perhaps the most serious complication, which would be an avulsion of the ureter. In contrast, the basketer says we focus on efficacy, we want the patient to be stone-free. To accomplish this, we need a basket, we need a safety wire because we're basketing, a sheath will help us go in and out of the kidney multiple times, and we'll leave a stent at the end of the case because we're placing a sheath. The duster says we'll save the NHS some money. because we'll need less equipment and our risk of stricture rate will be lower. The basketer says we'll save the NHS money because we'll get the job done in one go. There will be a lower risk of secondary procedures. Up until now, we really haven't had any evidence to tell us which of the two approaches is better. At the AUA meeting this year, we presented a prospective study of renal stones less than 2 centimeters in size. Now, our initial hope had been to perform a randomized clinical trial, but it's difficult to shift the practices of experienced endourologists who are getting good outcomes with their current techniques. So we identified 10 sites, 5 high-volume endourologists who do dusting, and 5 high-volume endourologists who do basketing, and did a prospective study collecting data in a registry to evaluate outcomes, with the primary outcome being the stone-free rate at 4 to 6 weeks with a KUB and renal ultrasound. When we compare the dusting and basketing, we see that a sheath is commonly used with basketing, but not with dusting. Only 1/4 of the times is a sheath used in the dusting group. The dusting is shorter in the operative times, 20 minutes shorter. It uses more laser energy because we're trying to dust the stone into small pieces. But the most important take-home message is the residual fragment rate. 31% for dusting, 9% for basketing. And indeed, 1/4 of patients had large fragments greater than 4 millimeters. So this suggests that dusting, though it may be safer, we don't know that because we still need to follow these patients out 1 year to look at the risk of stricture, may not be as effective. The risk of residual fragments, 31% versus 9%. The rest of the talk then will be about the tips and tricks for basketing the stone after you have broken it up with the laser. The other point we'll make, though, is we could ask, who is the patient? The patient has already been given the choice of shockwave, which is less risky and they have to pass the fragments. It sounds fairly similar to dusting the stone. They've selected ureteroscopy, recognizing that it's a little more risky, but they don't have to pass the pieces. So in my mind, the patient has already selected basketing over dusting. And occasionally we have to ask ourselves, who's the stone? One looks at the stone to the left, and one might go in there expecting to break it up and get the pieces out, but the pieces will be too small because it's a relatively soft stone. In that case, we have to shift our plan to dusting the stone instead of basketing. On the other side of the coin, we have a harder stone. And if one goes in expecting to dust this stone, chances are you'll have larger fragments that you'll have to modify your plan and go ahead with basketing the larger fragments. Tip 5 is always to use a ureteral access sheath if you're a basketer. The exceptions would be diagnostic ureteroscopy, or if you have a relatively small stone burden, less than 4 millimeters, where you anticipate placing the scope only once or twice. A ureteral access sheath will decrease the intrarenal pressures. Most of the evidence with regards to ureteral access sheaths in terms of protecting the ureter, decreasing intrarenal pressures, improving irrigation flow, enabling stone extraction, decreasing the need to empty the bladder, decreasing cost and operative time, and improving the longevity of flexible ureteroscopes is based on either in vitro data or non-consecutive studies without consistent references or standards. So level 3B evidence. One might ask, that's okay, why not use a ureteral access sheath? Some studies suggest ureteral ischemia when the sheath has been in more than 30 minutes. The risk of perforation has been reported to be 5%, but as we've seen, that has been seen in studies where a sheath is not used also. It has been reported that it's mandatory to place a ureteral stent after using an access sheath because there's a high risk, 37%, of unplanned emergency room visits if you try an unstented approach after using a ureteral access sheath. In our study, we found that if the patient is pre-stented before surgery, it's okay not to leave a stent, they do well. But if they aren't pre-stented before surgery, it is important to leave a stent. They'll have less pain with a stent than without a stent in that situation. So with regards to intrarenal pressures, a 12-14 French sheath gives you the optimal pressures. A 10-12 sheath, a smaller sheath, the pressures are higher, and a 14-16 sheath, the pressures are no different than a 12-14. Similarly, the irrigation flow is best with a 12-14 French size. The next question is, well, which sheath should I buy? When we go back to the days of not using a sheath, passing a scope over a wire, a common challenge was the scope would buckle at the ureteral orifice. So what distinguishes sheaths today is the buckling force. When we measure how much force it takes to buckle a sheath, we find that traditionally the Cook flexor was the stiffest sheath, and so it was least likely to buckle, more likely to advance up the ureter. Last year, Boston Scientific released the Navigator HD, which has a slightly higher buckling force, so I think represents an improvement over the Cook flexor. One might ask, well, are those forces too high? Is it more likely to perforate the ureter because it's too stiff? We find that the insertion forces used by staff surgeons is about the same as the buckling force of the sheath. So there's a built-in protective mechanism that if you push too hard, the sheath will start to buckle. And when we look at the amount of force required to perforate the ureter, again, the force for perforation of the ureter is just slightly higher than the buckling force. So it appears that there is a bit of a safety built into the sheaths, so they will buckle hopefully before you cause an injury to the ureter. We contrast that to recent findings by Professor Traxler from France, where we recorded endoscopic views of the ureter as the sheath was withdrawn at the end of the case, and categorized injuries to the ureter as grade 1 with a mild erosion, grade 2 where we start to see some smooth muscle but preservation of the adventitia, and grade 3 where one actually sees periureteral fat. He reported that severe injuries occurred in 13% of patients, grade 2 and 3, and some degree of injury was noted in almost half of the patients when they used a 12-14 ureteral access sheath. Patients that were more likely to have an injury were male patients and older patients. And they noted that preoperative stenting helped decrease the risk of a severe ureteral injury. So this raised the question if perhaps we should have softer sheaths, and Coloplast has a softer sheath. Another consideration was, should we have smaller sheaths? This design was from Terumo, where they developed a balloon-based sheath. One passes the balloon-sized catheter, inflates the balloon, and the sheath expands. So the hope would be that this would require less force to advance because it's smaller than a 12-14 French sheath when it goes up. Unfortunately, we find that the amount of force required to place the sheath, and this would be our traditional sheath and this would be the Terumo, this difference really isn't that great. And the reason is that though it's a smaller device, it's also a stiffer device. And so the amount of force required is almost the same. The other consideration is that when you have a balloon to inflate a sheath, when it comes time to remove the sheath, it takes more force to remove it. And indeed, we saw some cases of mucosal avulsion. So I don't think that the Terumo sheath is a safe sheath to use. The next tip is to only use a balloon in the distal ureter. If you have difficulty advancing your sheath or advancing your scope in the mid or proximal ureter, it's safest to put up a stent and come back 2 weeks later and allow passive dilation of the ureter rather than trying to balloon dilate. Typically, if we balloon dilate in the proximal or mid ureter, we'll see fat when one looks up with the ureteroscope. So we reserve the use of a balloon for the distal ureter and tend to pace up a stent if obstruction is met higher up. Tip 7 is to use pressurized irrigation to be able to see, and there's a variety of different devices, foot pedals, handheld pumps, and pressurized bags. In this study, we looked at how much force did the irrigation systems exert on the stone. So we had some simulated blood dripping in front of the stone and wanted to measure with the different devices which one was more likely to cause the stone to wash up to the kidney. First, we found that the Boston Scientific single-action pump required less pumps compared to the other devices, so it was more efficient at clearing the field of view. And secondly, when we measured the amount of force on the stone, it caused less migration of the stone compared to the other handheld devices. I will mention that the pressurized irrigation bags cause even less movement of the stone and may be a more cost-effective way to go for irrigation The advantage of the single action pump is when you really need a sharp burst to either clear the field of view or wash the stone from a dependent calyx to a more accessible calyx. It really gives you more maneuverability in terms of how much force one can generate. So when we use a single action pump, we place it in our hand this way, and the basket is in the thumb and the forefinger, leaving one hand free to advance the basket in and out as it closes to keep the stone in the center of the field of view. We switch now to what type of scope to use, and there's a variety of scopes from all the manufacturers that have small distal tips and exaggerated active deflection. In the past, it used to be that the durability of the scope could guide you as to which scope to purchase. But now we see a relatively level playing field. One can anticipate that the scope will break after about 15 to 20 uses, whether one uses a fiber optic scope or even if one uses a digital scope. So the durability of the digital scopes, unfortunately, are not any better than the fiber optic scopes. So if there's parity with regards to durability, how does one really decide which scope to use? A nice study from the Netherlands looking at fiber optic scopes showed that the optical quality based on low optical distortion, high resolving power, and a large field of view was best with the Olympus and the Wolf scopes, and was worse with the Gyrus ACMI. So I think really the scope size and the optical quality are the two parameters that are going to guide you as to which scope to purchase. Another thing that can be looked at is the maneuverability of the scope, and tip 8 is to use rotation of the wrists as opposed to twisting of your fingers. By twisting your fingers, you place stress on the scope, and it's more likely to break. So the majority of the work with the flexible scope should be rotation of the wrists and deflection up and down, rather than twisting the fingers that are closer to the patient. One of the challenges with the digital scopes is they have a bit of a stiffer tip. In this study, we found that about 10% of the time a digital scope could not reach the target, especially if it was in the lower pole. And in each of these cases, a small fiber optic scope was able to rescue us. So if you do make the switch to digital scopes, it's important to keep some fiber optic scopes available in case that digital scope cannot reach the target pathology. It is important to note that since this study, Storz and Wolf have introduced digital scopes that are a bit smaller and a bit more nimble than the Olympus and the DR8 initial versions. Now there is one place where the digital scopes can have an advantage with regards to narrowband imaging for upper tract TCC. So if you have a large patient population that you either are trying to diagnose upper tract TCC or monitor them for recurrence after laser therapy, the Olympus digital scope has some value. Indeed, 11% of the time, if one uses a traditional scope, one will miss the tumor, and it'll only be picked up based on the vascularity that's detected with the narrowband imaging. Tip 9 is to always use a 200 micron laser fiber. The small laser fiber will maximize your deflection compared to the lower right, where you have less deflection with the 365 laser fiber. It's important to note that what was on the package is often a misrepresentation of the size. Some sizes are very large when they say that they're actually 200 microns. There is a new laser fiber from Boston Scientific called the track tip with a ball tip, designed to decrease the chance of injury to the ureteroscope as one advances it in a deflect position. We looked at whether the ball tip is something that's durable or does it start to deteriorate the more you use it. We find on the left that when you use dusting settings, the ball tip stays, it doesn't degrade. Whereas if you use a higher energy setting for fragmenting the stone, the tip starts to degrade. So it's important if you're planning to use a higher energy setting to be careful as you re-advance the fiber, because it may cause problems with regards to the tip degrading. The next tip I'll give you is that for termites, they can get through wood a lot faster if they're listening to rock music. So there's a lot of rock music that came out of here. We typically listen to Led Zeppelin and The Who, and I think it really helps us with our stone fragmentation. Tip 10 is to always use a tipless basket. And just a quick summary of what we use: Sacred Heart Halo is a nice workhorse. The end circle is good for adherent intrarenal calculi, and the Cook and Compass is a nice webbed basket for small fragments in the ureter. Alpha blockers, though there's been a really nice study from the UK in the Lancet that really questions its value for medical expulsive therapy, we do have some lower level evidence suggesting that it's helpful for stent pain. So we do use an alpha blocker currently for stent pain in patients who have a ureteral stent. It's also important to consider pain when one removes the stent. When we did this internet-based survey, we found that a third of patients have fairly significant pain for a few days after the stent comes out. One randomized study from Dr. Conlon in Oregon suggests that using a non-steroidal for a few days after removing a stent may help ameliorate this pain. And lastly, selective imaging for ureteroscopy. We typically only image a patient if they had an impacted stone, a mucosal perforation, or a balloon dilation. This represents about 5% of our patients that we perform a ureteroscopy. So 95% of the patients do not get imaging after ureteroscopy unless they have pain. To summarize the top 10 tips and tricks, pick the right patient, be comfortable, use a safety wire, start with a semi-rigid, use an access sheath, only use a balloon in the distal ureter, use pressurized irrigation, maneuver your scope by rotation as opposed to twisting your fingers. Use a 200 micron laser fiber, use a tipless basket, and most importantly, when you run into trouble, in this case the sheath wasn't going up easily, we did a retrograde and saw some extravasation at the UPJ. Tip 11, is to always put up a stent and come back another day. Thank you.